Good afternoon, everybody, and welcome to Series 4 of the CEIH's Improvement Showcase. We're talking about innovation in chronic health management, and we're really glad that you've been able to take some time out of your busy days to join us today. So, first, before we get started, we'd like to acknowledge that the land that I am on today is the land of the Pemamunk people, and that many of you will be on the lands of the Kaurna people, and that we respect their spiritual relationship with their country. We also acknowledge these people as the custodians of their regions and that their cultural and heritage beliefs are still as important to the living people today. So together, let's create better healthcare for all South Australians. This is the vision of the CEIH, and we're really excited to have the role in our system of bringing people together. And that's exactly what we're here to do today, to bring you together and to have the opportunity to share stories so that we can work towards creating better healthcare for all South Australians. What if the big idea was connecting all of the small ideas? What if we all knew the wonderful things that people were doing just down the road, a few hundred Ks away, or maybe even not even a few hundred Ks away, maybe even 10 or 20 Ks away from us, just here in South Australia. So today we are hearing from our friends down at Barossa Hills Fleurieu Local Health Network, and we have Jörg Strobel with us to talk to us about Actional Intime Insights, changing the way healthcare is delivered. Next month, just a quick plug, next month we will be talking about vulnerable populations, and we have some fantastic speakers lined up for that series, for Series 5. I'm absolutely keen, if anyone would like to present at that you reach out and let us know. Alternatively, that you flick someone you know an email and say, hey, I know you've been doing great work with people in vulnerable populations. How about you get in contact with the CEIH? They'd love to hear from you. And we certainly would love to hear from those stories across the system if you know of somebody. So just quickly, the CEIH Improvement Showcase is about bringing healthcare teams together, and we do this Thursdays at 1 p.m, but also online whenever. So what will happen is we'll record the presentation from our guest, and then we keep that so that if people weren't able to make it at 1 o'clock on the Thursday, they can pop in and watch that any time that works for them. But then we want to provide a space for exploring what others have learned and actually having a conversation. So we turn off the recording, turn off the cameras, and give you the opportunity to have a conversation if you are able to be here for the live session. We really want to keep this simple. This isn't necessarily about publications or peer-reviewed improvements or peer-reviewed projects. This is absolutely about being able to tell a story and giving people a platform to do that. Before I hand over to Jörg, I just want to again ask if people do know someone who's got a story to tell, or if you yourself have succeeded in solving a problem, or you've learned something whilst trying, or you've got a theme that you'd like us to explore that we might not have touched on yet, or one that you'd like us to revisit from a previous series, please get in touch with us at ceih@sa.gov.au. So without further ado, I'd like to introduce Jörg Strobel, who is going to share his story with us today. Thanks, Jörg.
Yes, good afternoon, everyone. Now I just need to figure out how to share the screen again.
Excellent.
Now I think we are in business.
Yes, you are.
Now, Actionable Intime Insights is a project that has been MRFF funded for a number of years now, and I've been collaborating with Niranjan Bidagadi, who many of you will know for many years now. So he does the technical and system thinking with engineering and informatics background, and I try to be the party who brings that to the ground into clinical practice. All right, so considering the problem in health is that there is plenty of data around, but data is siloed and often disconnected, and therefore the healthcare provider lacks an overview about all the bits of data to have a comprehensive formulation. And what this leads to is that healthcare is often decontextualized from the longitudinal history and more reactive to the problem at hand. And so our endeavor was to make data more accessible in terms of data curation, to aggregate different sources of data and present them in a way that makes sense and is easily comprehensible. Data tell a story, and I don't know if you are familiar with the website Information is Beautiful. If not, you should go there, because there is all sorts of things that are visualized in terms of complex data sets. I guess my energy interests are represented here as a non-health example. On the left, the capacity for offshore wind production in relation to the actual demand. And you can see that we could power the whole world very easily with offshore wind if that would be a political intention to do. And on the right, this is my personal contribution to saving the planet. This is how solar cells and a battery in combination works. And I'm pleased to say that last year, AGL paid me money back. Now, closer to home topic in terms of visualized data sets relates to COVID. That is also taken from the Information is Beautiful website. And it's very helpful to have a few graphs like this if you have conversations with patients, in my case, usually, who worry about things and want to understand, you know, how badly am I at risk. And these kinds of aggregated representations are very useful in telling a story and giving people a sense of, in most cases, reassurance about the realities of risk, although in some cases, and in mental health, we have a lot of people who have many non-mental health comorbidities who fall into higher risk categories. All right, so what do we do in AI2? We are using administrative health data from the My Health record, specifically from the medical benefits, Medicare benefit scheme and the pharmaceutical benefit scheme, and aggregate them. And we have two representations. One is the patient timeline view, which is the representation of these kinds of data points on a timeline. And then the clinician's dashboard, they can have an overview over a whole population in your care. And that is what a patient timeline looks like. The blue dots, sort of in the middle sections, these are all medications, in this case, mainly antipsychotic medication and antidepressants. And the green dots are mainly GP appointments. And I guess the more compliant a patient is with medication pickup, the more regular the pattern would be. And in the system, there is, you know, an alert system engineered that sets an alarm if expected pattern by package size and so forth doesn't seem to be picked up in the time frame expected. And so here, this is only an image, of course, but if you are on the live website, going on each of the dots, hovering over the dots opens up another window that gives you more medication in terms of what specific medication it was, or what pathology investigation has been conducted, or what the particular item number of a GP was, which he billed or she billed for that matter. And the pathology details only tell us that a test has occurred. It doesn't tell us the test results. They are not recorded through the administrative healthcare system, obviously. But still, care plans, protocols of best practice can be embedded in this platform, so that if a patient should have, let's say, a prolactin test taken once every 6 months, that can be flagged. At the moment, we haven't embedded these sort of more sophisticated aspects, but I just wanted to flag this as the potential that the tool can become a monitoring device for best practice guidelines. So if we look at the clinical level, what does it tell us? Since medications are listed not just specific to mental health, but also for any other health conditions, the person reviewing that timeline view can then deduct also information about our comorbidities based on the kinds of medication prescribed. You know, if somebody is on a hypertensive antihypertensive medication, then the person is likely to suffer high blood pressure and so on. And the long-term patterns in terms of regular or irregular or clustered can then be also referenced to people's mental health state. And it's interesting to show patients these graphic representations, because one of the problems we have with patients with psychotic spectrum disorders is what is called a lack of insight. So that means that they don't have internal awareness that they are ill. And so I think everybody else has it in for them. And but when they then get sort of confronted with these data streams and see the pattern of adherence to medication, maybe under community mental health order in place, they had stable accommodation, possibly a job or a relationship, and once this pattern sort of fell apart, then a lot of the other aspects of life fell apart as well. And so that kind of visual feedback to their life story is often quite profound in terms of additional insights they can derive about their condition and life circumstances. Now, this is a case example of a patient on a community treatment order, and you can see that it's sort of pretty steady as it goes with medication dispensations and GP appointments at the bottom. That is a patient who became non-compliant, and you can see here a big gap because he ended up for a long time in a hospital, and only after a hospital discharge he sort of got into gear and to see that there is a regular pattern emerging. This is a ADHD patient with comorbid depression. And the top line, the top blue dots are the antidepressants, and the line below are psychostimulants, which are the typical treatment for ADHD. And it's not uncommon that people have sort of a stop-start kind of relationship to their stimulant medication. There is a regularity with antidepressant. There was a hesitancy. Do I want to get involved with that other treatment? But then with a delay of a good 6 months, the person decided to give it a more serious go. And what that led to is, and that is also often the case, that the depression is secondary to the impairment that comes with ADHD, that they continued with treatment for ADHD, but didn't require an antidepressant down the track. And you may have noticed that in October 2020, there is a bit of a gap, but the DDU is very, that's the drug of dependence unit in in the health department is very vigilant that people don't pick up their scripts too often. And so the three dots before were a little bit too tied together. And so they were told off basically, you know, stick to the pattern. And so they did. They was a good and compliant patient. So in terms of administrative benefits in healthcare management, seeing these longer term patterns gives also supervisors and case managers more confidence in their decision making, particularly also in determining when it's the right time to discharge someone from active case management. In principle, in mental health, we have an approach called easy in and easy out. We don't assume the role of being in people's lives forever, even if they have chronic and enduring illnesses, but we only step in when needed. But on the other hand, we don't do patients a service by discharging them prematurely and when they becoming non-compliant, relapsing, ending up in hospital again. And so the whole cycle starts all over again. And so to have these more longitudinal patterns available in the decision-making is helpful. Another application, which at the moment we can't realize yet because not everyone has access to the AI2 database, but at least in theory, that would be an important use case. We do have patients who are itinerant and don't go to the same GP or the same health clinic and sort of get washed up by the tides of life in various emergency departments. And so being able to see what the pattern of medication was in the past would be very helpful for the emergency physician to make a judgment about what is the regular treatment, how long has it not taken place, what is the likely best intervention at this point in time. Now, moving to the dashboard use, which is sort of more the administrative side to the application. The software in the background or the algorithm flags missing medications and appointments and produces a number of flags. And that's what it looks like. And you can filter in terms of red and green flags and filter by time frame and so on and so on. Sort of just to get an overview of the whole caseload under someone's particular responsibility, it's a useful tool to use. And it then brings attention to those people most in need or we should be most concerned about. Where we are at the moment is that we embed the regular use of AI2 into business as usual, and the model of care documents and the local worksite instruction documents are currently just revised to embed this into our care as standard practice. Now, while we try to push it into regular practice, it's still very much in a research stage of translating new insights into a clinical practice. And we have two lines of research. One is the implementation research to understand what is the impact on workflow. You know, there's the reality, but also sometimes overly labored narrative about we are too busy as it is, don't give us new things to do. So in some way, we need to be convinced ourselves and skillful in communicating that there is a net advantage of doing these things rather than just another bureaucratic act that is annoying, like many things we have to do. I think overall that is understood. And so while initially there was a decent amount of pushback from the clinical teams. Generally speaking, there's a greater openness and preparedness to use these things and gain familiarity. And then there is the quantitative aspect of research in terms of usefulness and accuracy of alerts. And there we also needed to do more tweaking and still have some work to do, because obviously we want to minimize the false positives and maximize the true positives, so that the balance of noise and signal is weighted towards signal. And that has turned out to be a more challenging task than I anticipated at the beginning. Now, in terms of some practical limitations, which also had some impact early on, is that there are some delays in the updating of systems. While we would like these things to be real time, there are some lags at different points of loading data sets into our application, because AI2 runs on a separate server in a secure, meeting health standards environment, but it doesn't run off the original data in Canberra. And so it only represents what is there in the administrative health records. So if people are in hospital or in jail or other sort of institutional settings, then obviously the provision of medication is not through Medicare and PBS billing, and therefore there is no signal, and that is not something we can do anything about. So while there is still work to do, it holds a great deal of potential. And having come from developing the basic software infrastructure to having now sort of a relatively successful pilot, we are looking forward to what it looks like at a larger scale. And we have one paper published and a few more to come. And that's it for now.
Fantastic. Jörg, thank you so much for sharing that story. It was absolutely fantastic. I know we had tried to get you on previously. We had a series around data in action, and not just looking at insights, but actually how can we start to involve those insights in the care that we deliver and the decisions that we make. So I'm pleased that you were able to make it today when we're talking about people with chronic conditions. So really fantastic. And certainly for me, when I heard about your work, the thing that resonates straight away is how we could not be doing this, and how we could not be using this data, not just for mental health chronic conditions, but for all chronic conditions. And certainly I think there's going to be huge opportunities for the work that you're doing. So very grateful to you and to the team for that. That's fantastic.